Hello, my name is Dominique Bojan, and I'm an assistant professor at the University of Tennessee, Knoxville. Today, I'm going to be presenting my poster entitled Association of Pregnancy and Community Race Distribution when Accessing Treatment for Opioid Use Disorder. So unfortunately, the opioid crisis remains a public health emergency with substantial worsening in pregnant women diagnosed with opioid use disorder. And there are medications for opioid use disorder, including buprenorphine and methadone, that are highly effective for preventing adverse health outcomes for both mothers and infants. However, most patients do not receive those treatments. So understanding the unique challenges and barriers that women face when they're trying to seek treatment for opioid use disorder is extremely important to help us improve care. So using data from a NIDA-funded secret shopper field experiment, we aim to determine if secret shoppers were less likely to receive an appointment if their race and ethnicity was not the majority race and ethnicity of the clinic where they sought treatment. And we also sought to see if this varied by pregnancy status and clinic type. So getting into the methods, primary data was collected in 10 states in the year 2019. 9 women were hired as secret shopper callers representing white, Hispanic, and Black vocal characteristics in the age ranging 25 to 30 years. We collected a number of individual level and community level variables. And a logistic regression model was fit to assess likelihood of obtaining an appointment by race and ethnicity and pregnancy status for predominantly non-white versus predominantly white community distribution after accounting for potential confounders establish a priority. So getting into the results on the far right here, over 3,500 calls were made in the primary study, and 23% of those calls were to clinics in predominantly non-white communities. Interestingly, there were no significant differences in obtaining an appointment by callers' race and ethnicity. In comparison to predominantly non-white communities, however, there were more buprenorphine waiver providers and fewer opioid treatment programs in predominantly white communities. And for our logistic regression, we found that each 10% increase in non-white community distribution was associated with a 6% increase in predicted odds of obtaining an appointment. So, and we also found that the likelihood of obtaining an appointment increased if the secret shopper was calling an opioid treatment program and if the caller was had an assigned status of not being pregnant. So table 1 here depicts our statistics. So to kind of summarize and restate, we found that calling for an appointment in predominantly white communities or being pregnant were associated with a lower likelihood of being accepted for treatment. And we also found that despite buprenorphine waiver providers being more likely to being in communities that were predominantly white and well-resourced, likelihood of obtaining an appointment increased if the opioid treatment program was called for treatment and as non-white community density increased. So this, of course, is an access pattern that is not typically observed in the United States. Typically, it's the opposite. So some plausible explanations for these patterns include racial disparities in access to buprenorphine and methadone, or racial disparities in access to buprenorphine and methadone that are linked to historic and structural racism in the distribution of treatment options for opioid use disorder. And another explanation for this uncommon pattern that we've noted here is that there might be a potential patient preference for buprenorphine as a less stigmatized treatment compared to methadone. So in conclusion, a health equity lens is crucial when crafting policies to improve access to medications to treat opioid use disorder, while also dismantling existing structural barriers. And some examples of some policies that could be considered include creating pathways to increase the number of providers that have combined obstetrics and addiction expertise, and making buprenorphine treatment accessible among public sector providers and opioid treatment programs. So finally, I would just like to acknowledge that this work was supported by an administrative supplements to support research on health equity in the National Institute on Drug Abuse. And thank you for listening and enjoy the rest of the workshop.